Hi again, it's me again. All right, now I want to talk to you about John. He looks like Robert De Niro, but it's not Robert De Niro. It's a random picture of a person. Anyway, I met John in my emergency department. 70-year-old gentleman, father, grandfather, who has been, he's relatively healthy. He's been sort of short of breath for one day, thought maybe he's getting a URI, maybe COVID, and so decided to ignore it like every other patient who has a complaint. And then towards the end of the night, he started becoming more and more restless, more and more short of breath, and then eventually collapsed. His wife called 911, who came at bedside and found him in PEA arrest. And so they started CPR, and they brought him to my emergency department. And sure enough, he was in PEA arrest. We continued the ACLS protocol, gave him epi, I even gave him bicarb and calcium, because I didn't know what we were dealing with. And unfortunately, like every other patient I had today, he died. But those of you who know me already, and I think some of you already spoken about it in the chat, John, when he came to my ER, did not actually die because I echoed his heart. And this is what I saw. A large pericardial effusion causing pericardial tamponade. So instead of calling it and ending the code, he got a pericardiocentesis. I drained some fluid from around his heart, and he walked out of the hospital intact. So I'll talk to you today about when to stab the heart when we're dealing with pericardial effusion and tamponade. So whenever you see fluid around the heart, you need to ask yourself two questions. One, is this fluid truly in the pericardial sac, or is it in the pleural sac or pleural space? And if the fluid is in the pericardial sac, is it causing a problem? Is it causing tamponade? So let's tackle the first question. So you can see fluid pretty much on any view, but the parasternal long view will help you because you have a landmark, and that landmark is going to be your descending aorta. Any fluid that tracks in front of your descending aorta, anterior to it, is in the pericardial sac. So that's pericardial fluid. Any fluid that tracks behind it is going to be in the pleural space. So in this example, you have the descending aorta, and then you have the pericardial fluid tracking anterior to it, and you actually have a larger pleural effusion going behind it. Here's another large effusion, and because the fluid goes in front of or anterior to the descending aorta, this is a pericardial effusion. Here's another example where you see a large body of fluid, however, it is tracking behind the aorta. So this is all pleural. You can actually see a very tiny effusion there in this example. So this is all pleural effusion. And here you can also see a pericardial effusion going anterior to the descending aorta and a pleural effusion going behind it. All right, so now that we know where the fluid is, and if you find fluid around the heart, is it causing tamponade? And when you're telling me tamponade, you're telling me that the pressure in the pericardial sac is big enough to cause impedance of the filling of the heart. So whatever pressure is being exerted by the fluid in the sac is stopping the heart from being filled. And we know that the right side of the heart is the lower pressure system, so it will be affected first. And so you're telling me that the pericardial tamponade, by using the word tamponade, is preventing the right atrium from filling and preventing the right ventricle from filling. So recall again, when does the right atrium fill? Well, the atrium fills when the tricuspid and mitral valves are closed. And then the ventricle fills when they're open. So the atria fills in systole when the valves are closed, and the ventricles fills in diastole when the valves are open. So again, if the pressure from the pericardium is large enough to prevent filling of the right atrium in systole, that is tamponade. If it is preventing the filling of the ventricle in diastole when the valves are open, that is tamponade. So let's look at it on echo. So yes, you can slow down your clip. However, I found it to be much easier if you freeze and scroll back to where you find the valve is closed. So now you know you're in systole. And right now you want to look at the atrium because that's when the atria fills. If you see any inbowing of the wall, any indentation, any sign that there's pressure from outside that's preventing the atria from filling, that is tamponade. Likewise, if the valves are open, you know you're in diastole. You look at the right ventricle. If it's being pressured or there's any inbowing, then you know that this is tamponade. So now let's say you can't get a great apical four-chamber view. You can actually use the parasternal long view because the mitral valve and the tricuspid valve close and open at the same time. So you can use your mitral valve as a surrogate for the tricuspid valve when you're looking at the right side of the heart. So if your mitral valve is open, you know you're in diastole, so you look at the right ventricle. If there's any inbowing there, you worry about tamponade. That's pretty much it. So if you have pericardial fluid that tracks anterior to the descending aorta, that's in the pericardial sac. If the atrium, the right atrium, collapses in systole, you worry about tamponade. And I have a small mnemonic. It's asystole, so atrium in systole, just to help me think when I'm on my feet. And then the right ventricle, if it collapses in diastole, you worry about tamponade. Thank you.
Okay, Leen, I got one question for you.
All right, we got questions.
Sorry. You're getting just too good at this with all the POCUS talks. So my one question is, we're emergency medicine physicians. We always think of the worst. But sometimes our consultants tend to try to minimize our concerns at times. So what are the key phrases or things that I should be telling my cardiologist if I think they have tamponade to really convince them that I know what I'm talking about and they need to get to the bedside?
So a lot of these changes on echo happen before clinical change, before the Beck's triad that we know, right? So if you tell them the atria is collapsing in systole, that's automatically echo lingo for tamponade. Or the ventricles collapsing in diastole, echo lingo for tamponade, right? If you give them the large, so we can also measure the effusion size. Sometimes they would, if it's a very large effusion, they would actually respond. But I think they also want to see clinically what the patient's doing. So if he's a little tachycardic or short of breath, that also points to more an urgent situation. Sorry, I'm supposed to look here.